Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am delighted to welcome my guest today, Professor Amitava Banerjee, who is the Chief Investigator on the STIMULATE-ICP study taking place in the UK. So I'm really looking forward to finding out a load about this. So welcome to the podcast, Ami.
Thank you very much for having me, Jackie.
I'm really excited to have you here. So to start with, would you mind just giving a brief introduction of yourself and what it is you do?
Certainly. So I am Amitava Banerjee. I am a cardiologist, so a heart specialist in London at two hospital trusts, Barts and University College London, but I'm also a professor of clinical data science at University College London. And where am I research at? I'm trained in epidemiology and data science, so looking at large data sets to spot trends in what's happening with disease at big picture level, if you like. And during the pandemic, since the beginning, I've been interested in the different ways that the pandemic has led to both acute effects, but in the case of long COVID, more chronic effects, and which led to this current research in the STIMULATE-ICP study.
Wow. So it sounds to me like a very busy existence that you have there. But I suppose it's this kind of big data set that is particularly what you're kind of looking at here.
The STIMULATE-ICP, let's dive into that, because you're right, there is definitely a big element of, or elements of data analysis going on, but also intervention studies and looking at inequalities and so on. So the acronym STIMULATE-ICP is a mouthful, because we were trying to do a study that, in the words of Melissa Heitman, my colleague and co-chief investigator of this study, she's the national lead for long COVID and started the UCL long COVID clinic. She talked about building the plane while we're flying it, in that we're trying to define and understand long COVID at the same time as needing to treat people because of so many people being infected and affected by long COVID. So it stands for symptoms, trajectory, inequalities and management, understanding long COVID to address and transform existing integrated care pathways. And I have to look that up because it's a mouthful. But in essence, it's looking at the description and definition of long COVID. It's looking at the trajectory of long COVID and the management of long COVID. But also the ICP bit is looking at integrated care pathways. Now, integrated care pathways are not new to COVID or long COVID. If you take chronic obstructive pulmonary disease, COPD, or heart failure, I'm a cardiologist, that's a disease that I'm specialized in. It's where you have an integration of care across primary care in hospital, from community to the hospital. It's where you're kind of trying to take a big picture view and holistically look at the whole pathway of patient care. And that's what we were trying to do in the STIMULATE-ICP study. And both myself and Melissa Heitman are kind of that way inclined in terms of integrated care and zoom out kind of clinicians, if you like. That's our approach to chronic disease. The STIMULATE-ICP study has three parts. The first part is describing the symptoms and characteristics of people with long COVID and their trajectory over the first 3 years of the pandemic. And we're doing that in a number of ways. In terms of quantitative data, we've got really detailed electronic health records from University College London Hospital, where Melissa and team have been they started this clinic in April, May of 2020. So it's remarkable, really, that they had the foresight to do that. And we also have access to national electronic health records. And we're also working with NHS England to look across the 90 clinics in England that have been set up to see what data we can look at. There's a bit of detective work to be done there because the coding is not perfect, but that's something we're doing. We're also interviewing people in the different clinics that we're focused on. So we're in our study we're particularly looking at 6 clinics around the geography of England. So Hull, Leicester, Derby, Liverpool, Exeter, and London, and we're interviewing patients and healthcare professionals to see what care has been delivered over the last couple of years. And then in the second part of the study, we are doing this large complex trial, and it's looking at across the pathway at 3 things. One is an investigation, which is a multi-organ MRI scan called cover scan. 2 is a platform drug trial. So like what has been done in acute COVID in various trials, like the recovery trial, panoramic trial, we've started a platform study with 3 drugs initially, which are colchicine, which is an anti-inflammatory drug, rivaroxaban, which is an anti-clotting drug, and a combination of antihistamines, loratadine and famotidine, which are also being used. And this trial is looking at the whole pathway, but each of those components as well. And what we call the primary outcome is looking at fatigue at 3 months on something called the fatigue assessment scale. But we're looking at a whole host of different physical, functional, psychological, and so on outcomes. Also from that trial, well, from the cover scan, we're getting information about organ function, but we're also taking bloods from these people. We're aiming to recruit 4,500 people. So this will be the largest biobank of information for the global research community to find out about and quickly research the different aspects of this new disease. And that trial we're hoping we'll be able to recruit fully by beginning of next year, in 2024. The third part, where I know you've spoken with my colleague, Professor Nisreen Alwan, as well. So Nisreen and colleagues are leading work looking at inequalities in provision of care for long COVID across different clinics and geographies and communities in England and the UK. And also we're looking, this work is led by my colleague, Professor Christina van der Velds-Cornelis. She's at York University and is a psychiatrist, but she's interested in comparing long COVID with other long-term conditions, from cardiac and respiratory to mental health and other diseases such as ME/CFS. And the reason to do that is to compare the healthcare utilization at scale for this disease, long COVID, but also to see what we can learn beyond the pandemic for treating long-term conditions and planning for them in future. So that's an example of how we've bitten off more than we can chew, and we're working hard at it. It's a massive piece of work funded by the National Institute for Health Research. It's one of the core funded national studies for long COVID, and we're very grateful to our funders, but also it involves universities, hospitals, charities such as Long COVID SOS, industry partners such as Perspectum, who developed the scan, cover scan, but also, I should have said, in the trials, we're testing a digital rehabilitation platform called Living with COVID Recovery as well. So our industry partner, Living With, are providing that as well. So yeah, it's hopefully answering a few different things, and we could have taken one or less of those parts, but we felt that actually that would mean that you're kind of just looking at the arm and not looking at the whole person, or just looking at one bit and not looking at the whole system. So that's the ethos.
Yeah, I mean, like you say, it's quite a lot, but long COVID is quite a lot in itself, isn't it? It's got lots of different variations of it, but also it affects people in many, many different ways as well. So it doesn't just affect your physical health. That's maybe the most outwardly obvious part of it, but it affects all parts of your life. Your physical, your mental health, your family life, your social well-being, the list goes on, doesn't it? So like you say, it is a big thing. You just mentioned long COVID SOS, and I was wondering if was that part of your patient participation kind of arm? Maybe is arm maybe the right word of that? Because it's definitely something I had never come across until I got long COVID, and then started looking into kind of research and this idea of patient participation, and that it just never crossed my mind that patients could and should be involved in research. But actually, it's really important, isn't it?
So Jackie, thanks for raising that. I have been doing medicine and doing research a while. I know this is an audio podcast, but you can see I've lost some hair. So, but PPI, or patient and public involvement, which is now more often referred to as PPIE, patient and public involvement and engagement, it's been part of the process for some time, and I've been involved, whether it's cardiology patients, people with diabetes, my homeless patients who have cardiovascular disease. But I think during the pandemic, I myself have had a bit of an epiphany in the need when you have a kind of public health emergency that we have had, both acutely with COVID and with long COVID, where you are defining the disease and trying to design services. It's absolutely essential to have patients with lived experience and their carers or others who are involved in the process at the table, and not just involved, but leading the agenda. I often say Long COVID SOS and other patient-led organisations raised awareness of this disease and called for research, rehabilitation, and recognition. And that's why the grant calls were put out by the government. So I think we've been involved with not just long COVID SOS, but different patient groups since we applied for the grant, since we started writing and they were involved. But during the project, we have developed a stronger and stronger PPIE panel for STIMULATE-ICP. We now have 11 regular members. We have monthly meetings, an active WhatsApp group, and we don't do anything without involving them, whether it's writing scientific papers, whether it's just recently we've put an amendment in to our study because we're having difficulty recruiting in some of our sites, and so in some sites we're going to be recruiting drug-only patients, not to the rehabilitation and the scanning, in order to increase numbers and answer the questions about drugs quicker. That's been with the blessing of our PPI panel. And through a charity like Long COVID SOS, and I should say, over the last 9 months or so, I've been a trustee of Long COVID SOS as well. So, so I've got a conflict of interest, but in a good way, I think. It allows us to survey and access a wider community of patients. And there are several charities which are linked, and they're all on the same team, really. But we need to, I think we need to keep listening as researchers and clinicians. I think also we need to do better. This is for the patient organisations and charities as well, to make sure that we're representative. I think there's a tendency that the Twitter sphere is all the voices of people with long COVID or patients, and of course that's not the case. And we need to strive to find the people who haven't been heard or aren't represented there, and that's more challenging work. It's easy to kind of respond to the Twitter noise. So I think PPIE, to summarise, is really in our DNA, and we've had loads of really big successes through that. For example, Watch This Space, the STIMULATE-ICP patient panel have led an ebook about their lived experience of long COVID, which at best I facilitated, but they've set the agenda for that. They've written that, they've edited it, and it's going to be coming out from them, which we're very, very proud of. But that's what happens if you involve patients on their terms, I think.
Yeah, and that's really, really wonderful. I mean, you've kind of just highlighted two things to me. One is that, as important as PPIE is, it's not easy. It's not just having a quick chat with a couple of people. It's much more of a thing, isn't it? But also this idea of bringing people together, and everyone gets something out of it. I've definitely found that through doing this, I've made connections with people that I would never have done otherwise. I find myself sitting here speaking to someone like yourself, and it's and it's all these kind of connections and people that I've met, and and some of who I would now call good friends, and all of these things that have been made out of this awful situation that we find ourselves in. But the sense of community, really does make a difference, doesn't it? I think, well, to everybody.
Yeah, I think if you asked members of our patient and public panel, they would say that friendship and support that they get from each other, as well as joining. They join all of our kind of team meetings. They're part of the team, and I think they find it reassuring that we are all on the same team trying to work together. Whereas sometimes, if we don't do it that way, it can feel like they're not being involved, or it can feel like things are being done at them or to them, and that's not the case. I should say we're not the only research study by a long way that's doing this. I think across the NHR long COVID studies, the patient and public involvement has had to be strong to push us along.
Yeah, definitely. I'd love to talk a little bit more. You described your three kind of arms, if that's the kind of correct word. You've got your describing symptoms, and you said the data for that goes all the way back to April 2020, which is amazing, because in April 2020 I couldn't get out of my bed and didn't know what was happening. So it's amazing that there was actual kind of like gathering of data and research already happening at that point.
Yeah, well, outside of the UCLH clinic, where Dr. Melissa Heitman and colleagues were setting up the first long COVID clinic, definitely in the UK, and maybe wider than that. At the same time, my colleagues at Perspectum, which is a company that prior to the pandemic was specialising in imaging of the liver, and by imaging I mean doing scans. They use MRI, and they were tasked to develop a quicker solution to assess multiple organs, and the purpose was originally to prove that COVID doesn't affect organs, not the opposite, which is what we found. So in that study, we recruited people from April to September 2020 and then followed them up for a year. And in a quite unique data set, the data is being published late, but it's coming shortly in the Journal of the Royal Society of Medicine. It will be published to show that there's lasting signs of organ impairment at 1 year. In the first wave, there was anyway. We'll be able to compare that with the data from STIMULATE-ICP, where we have people in the era where you had vaccination, where you had better treatment of COVID, both in the community and in intensive care and in the hospital, to see whether the same degrees of impairment are being seen. So yes, we have that. We have a huge research effort around the world, some of it led by patients and public themselves, which has looked at symptoms and looked at clusters of symptoms, looked at different investigations, looked at trying to understand who recovers, who doesn't. On the clusters, we're not there yet. We would love to be able to say to somebody on the basis of the symptoms or the tests that we do, oh, you're suffering from this variety of long COVID, which is going to get better in X number of months, and oh, this other variety is one that seems to be harder to recover from, or this one responds to this particular treatment. This is the type of granularity or precision that we don't have, despite all of the studies and despite what you might hear in media or social media. That's what we don't have. That's in a scientifically reviewed form, and also in terms of treatments, there are lots that people have tried themselves out of frustration and desperation. But what we need is to understand what's placebo effect, what's real, particularly because people until now across the world paying out of pocket for whether it's supplements, drugs, different treatments. And so I think the trials effort needs to be upscaled, but there's challenges there as well, because the disease definition, who you recruit into the study, is important so that you're comparing representative spectrum of the disease, but also one that you can understand and analyze. And then also, which outcomes should you look at? Is it just fatigue? Is it some kind of combined or composite outcome of different things? So all of these things, we know what to do when it's a disease like heart disease or heart attacks, because we've done that for 50, 60, 70 years. We've had to design all of that in long COVID. So it's not easy.
Yeah, and that's where this kind of very broad illness becomes very, very difficult, doesn't it? Because, like you say, how do you actually measure it? Do you measure it on, which particular symptom? And, everybody has different symptoms. A lot of them cross over, but no two people's symptoms are exactly the same. And, of course, then, different people's symptoms are different on different days as well. So it must be a really, really difficult thing to kind of be able to show your results, I guess, even if you do find something.
Yeah, so as a researcher, you're watching and learning and analysing, and there's all of the above to be done in this. And I think trying to get the best possible data that we can is the first step. And as I said, there's lots of people doing that, but getting the funding, getting the research through ethical approval, getting it started, all takes time. And I think it's important to note, although the progress might seem slow to many, not least the people suffering with long COVID like yourself, that there's more progress been made in this disease that we didn't know about until middle of 2020. In those 2.5+ years, we've learned more than pretty much any other disease that's just been recognized. The kind of mobilization we couldn't have had in different areas, and there are many advances both in the rehabilitation side. Also, there's some that, for example, we know that keeping your infection and reinfection rate down helps. We know that vaccination, although not curative, helps. So getting your vaccinations is a good thing, and these things weren't there in March, April, May, October 2020. So there's lots of progress, but lots to be done.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Yeah, I think that's a really good point, actually. As patients, we are sitting around going, why isn't this fixed? What is happening to me? Why am I not better? And we are all frustrated and we're all ill and we want to be not ill. But actually, there are a lot of people working, probably more hours than they should be in order to try and do something about this. And I certainly find it quite sobering when I remember or am reminded of people with ME/CFS, for example, who have been sick for decades, and I think been largely ignored, certainly by a lot of people. So that's a very good point, actually. We're not going so slowly as maybe we feel like it.
And I think also it's important to remember that many of even our own research team, but the broader scientific and clinical community are affected by long COVID as well. So, we've had some of our work delayed in inverted commas because people have been off sick. People have been unable to work, but they're still working hell for leather on this. Then obviously we've got, I mentioned our PPI panel who by definition have long COVID or are caring for people with long COVID who are also giving up time to do this. So it does take up a lot of woman or man hours.
Yeah, definitely. Yeah. So what kind of stage are you at the moment? Are you said you're still recruiting for the trial part?
Yeah, we definitely are. We're up to about 400 people recruited, and we want to get up to 4,500. That's what we were funded to do, and that's what we aim to do with the help of you, the public. And we need to understand that we haven't maybe been able yet to recruit as quickly as we'd like. And some of that is because people feel that we need to be looking at other drugs or they want to be in other studies. But in order to get to that, we need to answer the questions. For example, if we don't test this one anticoagulant, people have asked, why aren't you testing 3 anti-clotting drugs together? Well, the answer is because we haven't got evidence that even one works in a trial setting yet. Also, in the heart field, in cardiovascular space, we deal with the clotting and anti-clotting drugs a lot, and giving them in combination like that carries a bleeding risk. And you wouldn't get ethical approval to do that without evidence of it in a one combination or 2. And yet, if you go on Twitter, people are asking for why aren't we giving triple combination already and doing trials of that. That's why we need to do this trial first. So I would encourage people to bear with us, and the worst thing that can happen is that we don't follow good evidence-based science. We've got decades of experience that if we end up doing things without that basis, then we can end up going down rabbit holes or into cul-de-sacs where we're doing things that might actually do harm, or we might be giving people no more than a placebo effect, which costs them, their savings. So I think this is an important study that will give us important answers so that we can scale up the right long COVID services.
Yeah, of course, because there's a lot of sort of hoops to jump through to get anything up and running, isn't there? And you've got to get all those boxes ticked before you can even actually start doing something.
So there are hoops, and there's a lot of red tape and bureaucracy, but a lot of it is there for a good reason. But I wasn't even talking about that. I was talking about the fact that science is an incremental step. So you very rarely have the moonshot that gets you there. You kind of find evidence that there are clots. You try one clotting drug, it works or doesn't work. Why didn't it work? And you try another. You try in combination if you've got some evidence that it's helping, and build up rather than going straight in for the big project. That's how it works, both for ethical reasons and funder reasons, and just the way we gather knowledge.
Of course, so it's building up that kind of evidence from the bottom.
Absolutely.
Yeah, that makes sense. How do people get involved, and have you got any kind of criteria for people getting involved, or is it literally anybody?
Yes, so the STIMULATE-ICP study for the trial, we do definitely have criteria. Because we're looking at this pathway, you have to be in one of our sites. And so initially it's Hull, Leicester, Liverpool, Derby, Exeter, and North Central London, served by University College London. We're going to be adding 2 or 3 more sites and possibly more. At the moment, we're looking at people who are referred to the long COVID clinic and people who are being seen for the first time. We had to do that as well, rather than people who've had treatment already and had long COVID for some time, so that we can tease out what works in that, if you like, early in their disease process and untouched population first, before we roll out to people with later disease. And we picked, people ask, why are you only going for people who've been referred to clinic? It's because of that problem that we're trying to pick the population who've been assessed by clinicians and got the firm diagnosis of long COVID, so that we can again find the answer or not before we go elsewhere. There are other studies which are recruiting more in the community and more widely, but this is how we'd set up our study. So anybody who's referred by their GP in those sites can be referred to our study, and hopefully other sites will be coming at you very soon.
Fantastic. Yeah, so hopefully you'll get loads more people. So, Bob who lives in Cornwall, for example, wouldn't actually be able to sort of say, I'd love to get involved in this, but at the moment that wouldn't work.
Bob from Cornwall might actually be served by Exeter, so he's lucky.
That was a terrible example of a place then, wasn't it?
Yeah, but it raises the point, Jackie, that the different clinics are serving really different geographies. Hull, where I'm from originally, which is one of our sites, serves the whole Humber area from North Yorkshire to South Humberside, Grimsby, Scunthorpe, so on. And so geographically, getting tired patients to a clinic that might be an hour or more away is no mean feat. Getting them to do scans and repeat visits and fill in lots of questionnaires. But yeah, some of our clinics cover wide areas. Derby is another site where there's a wide geography that's covered in the East Midlands.
Cool. So it's definitely worth checking if you're sort of within.
Yeah, we have a website. Look up stimulate-icp.org is our website. You'll find up-to-date patient information, new sites, the protocols of the study, publications, videos about the study. But there's also the non-trial parts of the study, whether it's about inequalities or discovering about the disease, where people don't necessarily have to be at the sites. So do get in touch with us.
Perfect. I will make sure that the link to that website goes into the show notes. So if there's anyone who is interested in any way in the study, but also might be interested in taking part in whatever way, so whether they're able to get to one of the sites or not, make sure you check that link out. Perfect. Well, Thank you so much for joining me today. It's been really, really interesting hearing about all of this. And thank you for all the efforts that you're putting into it as well. And maybe you'll come back and talk to me when you have some of your results.
We'd love to, Jackie, and I'd love to come back and tell you about results.
Wonderful. Thank you so much.
Thank you.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch